Hello, Sabrina. How are you?
I'm good. How are you?
I'm good.
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 I'm just driving to my house, so.
Oh, okay. Let's see who else we got here. Okay. Bill Dodson, are you with us?
Hola, señor.
Okay. I'm going to give people a couple of minutes to join, and then I'll let you give your PSA.
Do you want to do it at the end so we can make sure, or near the end?
Sure.
That way everybody's here.
That'll work.
Thank you.
Dr. Brooks, I'm here, but I am driving home, so if I don't comment, that's why.
That is fine. That is just fine. Let's see who else we got. Kelly's with us. And looks like VJ is with us.
Yes, sir.
From, from Houston, Texas, right?
Yeah, Houston's it.
Yep. Okay. Anthony Durant. I don't know that I know you. Welcome. And Scott is with us. I just unmuted you.
Hello.
Hello, how are you? Oh, you look relaxed.
I'm in my lazy boy chair and
I wish I was in my lazy boy chair. I had an 8 a.m. start this morning with a 1 hour drive to get there, and I don't even know how many cases I did. I did 8 or 9 or 10 cases, and then an hour drive back. So yeah. Let's see who else. Yeah, we'll give folks about another minute or so to check in, then we'll go ahead and get started. So I do have a presentation to do, but obviously, as my presentations tend to go, it tends to end up being where we just sort of open it up and let folks ask questions and have discussions. So we will plan on doing that also. Okay, and it looks like in the chat, Anthony says my computer does not have audio or a microphone. So that's fine. Just follow along. Okay. So before we start, does anybody have any questions that they would like to ask, or has anybody had any interesting cases or situations here the last week or so? Anybody?
I'm pretty new to this, so I haven't done a case yet. I haven't got my 25 in. So.
Oh, okay. So you are a very, very newbie
Yep.
then. So
I'm not going to be contributing much.
That's okay. Because what I figured I would go over the last time I spoke, the topic was on grading the severity of carpal tunnel syndrome. And tonight we're gonna go over grading the severity of cubital tunnel syndrome. And what's interesting about that is we can apply some of the same standards that we use when grading the carpal tunnel to the grading of cubital tunnel. And for those of you that don't know, cubital tunnel syndrome is ulnar neuropathy at the elbow. Well, let's go ahead and begin. And let's see here. There it is. Okay. Okay, so those of you that were with us here about 4 weeks ago or so, would anybody care to share what some of the findings that were applicable in carpal tunnel syndrome as it relates to it being mild or moderate or severe? What's a common finding that we see when we suspect or we have a case of a focal entrapment that is just graded as mild? What type of abnormalities are you going to see in a mild, focal entrapment?
Prolonged latencies of the sensory.
Okay, so yes. Okay, so you're going to see slowing of your sensory nerve conductions, and that could manifest either as a prolongation of that sensory distal latency, or it can be slowing of a specific segment of a sensory nerve, such as the transcarpal median segment. What else? Other than slowing, what other phenomenon might we see that would be considered to be mild?
What about sensory comparison studies?
Yep. So anytime you do a comparison study, is that going to be rated as mild, or is that going to be rated as very mild?
Very mild.
Very mild. Okay, so whenever you compare one nerve to the other, or if you're just analyzing a short segment of a nerve, 8 centimeters or less, and you see slowing, then that's going to be considered to be very mild. How about conduction block? What about, say, a 40% conduction block, of a nerve? Would we consider that to be mild? Anybody?
That's benching towards the moderate, isn't it?
Well, no. 30-40% is still going to be mild. What type of abnormalities do we need to see to step into the moderate category? So what type of sensory abnormality do we need to see to be to consider it to be moderate?
No results. No response.
Well, no response of a sensory is severe. That qualifies as severe. What might we see before the response actually disappears?
You talking about sensory or motor?
Sensory, right now. As you lose more and more sensory axons, but you're not to the point of the response being absent.
Diminished amplitude.
What is that? What's that sensory nerve going to look like? Let's see, we have a chat. Anthony's saying prolonged latency, but latency, remember, is slowing. Okay?
You have diminished amplitude.
Diminished sensory amplitude. Okay, so as you start, as the lesion becomes more and more severe, and it progresses beyond just damaging myelin, which will cause slowing. And it now penetrates the axon component of that nerve. As it damages more and more axons, you're going to progressively see a decrease in that sensory amplitude until ultimately you damage enough of those axons and you're not going to get a response at that point. And anytime you don't have a response at your distal stimulation site, then that becomes a severe lesion. Okay. Okay, so to sort of summarize, the sensory nerve, very mild severity usually involves either an abnormality when you're doing a comparative study or a short segment study. Okay, mild generally involves just slowing of the full length of that segment, like in the median nerve from the wrist out to, say, D3. When you start getting into moderate, that involves losing axons. Okay, and at that point, as you progressively lose axons, the sensory amplitude is going to decrease until progressively you've lost enough axons that you no longer have a response with that sensory nerve, and that now qualifies as a severe lesion. Okay, how about the motor nerve? What type of findings would you expect to see in a very mild or mild lesion? Is it going to be very, very similar to what you see with a sensory nerve? Anybody? Oh. Okay, so Kelly's asking, and again, Kelly, are you guys still muted? Hang on here. I need to.
I think, so basically a comparison from the median and the ulnar at the wrist.
Hang on one second. I'm gonna unmute folks here. I know some people are driving, but I've just unmuted everybody that I can unmute. So with a motor nerve, mild and very mild findings, as Anthony mentioned, is it's going to be similar. Okay, so I think Bill, you said median to ulnar motor latency comparison in the same hand. Okay, if that's abnormal, then that's going to qualify as very mild. Or comparing, say, a median latency in one hand to the same nerve in the other hand. If there's a significant difference, that's going to qualify as being, as being very mild. In terms of nerve conduction under velocity, and let's talk about the ulnar nerve, for example. It's not unusual for us to see slowing of the ulnar nerve across that elbow. Okay, and so Kelly, I'm going to try. Actually, Kelly, it's saying that you're not muted anymore here. So motor slowing, say for example, across the elbow, in a 10 centimeter segment across the elbow, that's going to qualify as mild. even if it's 30 meters per second versus 40 meters per second, that's still mild. Okay. So let's talk about motor as it pertains to a more moderate type of lesion. What type of abnormalities will we start to see in a moderate motor lesion?
Maybe some axonal loss.
Yeah, so how would that manifest, Mark?
Basically it'd be below what you would consider normal, and then you'd have to check side to side, and then you'd have to confirm with EMG.
Well, yes. So the start of a decrease in that CMAP amplitude, in that motor amplitude, along with needle EMG abnormality. Okay, so so both of those qualify as getting into the moderate level of a severity. What's unique for carpal tunnel syndrome, for the median nerve, a distal latency greater than 4.5 milliseconds also qualifies as a moderate finding, and that's about the only situation in which we see a prolonged latency qualify a lesion as moderate there. How about severe? What type of findings are you going to see in a severe motor lesion?
No response.
Yeah, it's going to be a significantly decreased amplitude. So, so an amplitude that's at the 10% level of that lower limit of normal. Okay, so for example, the median, there you go, Kelly. The median motor amplitude is our norm is around 4 millivolts. Okay, so if it's 3.5 millivolts, because we've had some axon loss, that's going to qualify as being moderate. But what if that amplitude starts to drop to where it's down around 0.5 or 0.6, where it starts to become very, very small? Then that certainly qualifies as a severe lesion. And what are you always going to see with a lesion, with a motor lesion that low in amplitude? You're going to see an abnormal EMG. Okay, and what specifically are you going to see when you do that needle EMG? When you've lost 90% of your motor axons.
Muscle membrane instability.
You could see that, but what's going to be even more striking than that?
Increased amplitude.
Firing.
I'm sorry? Kelly?
Okay.
I was thinking, depending on how far along, and I'm still trying to understand what happens in that process of the sprouting, the collateral sprouting, but so, less motor units and higher amplitude.
Yeah, so you're going to see a reduction in the number of volitional functional motor units. And at what type of firing rate are these things going to be firing at when you've lost 90% of your axons?
They're going to have to be faster.
Be fast, yeah. So the most striking thing that you're going to see when you have an amplitude that low and you do have a few functioning motor units left, in order to try to maintain force and generate force, that very small number of functioning motor units are going to have to fire faster and faster and faster, what is the normal firing rate of a motor unit? Up
About
to
10,
how
12.
fast? Up
10,
to about
12.
how fast? Yeah, around 12, maybe 14. Okay. But
Can you
if
say what? 12 to 14, what milliseconds?
no hertz,
Hertz.
yeah, cycles per second. Okay. In a completely normal muscle, when does the, at what firing rate does the second motor unit come in? Bless you.
Thank you.
About 6 to 8.
Yeah, between 5 and 10 hertz. Remember the rule of fives. Okay. When you isolate a single motor unit on your screen and you start to generate force to that muscle, somewhere around 5 hertz, where it's firing 5 times per second, then usually you're going to see a second motor unit come in. And then when that original motor unit is firing somewhere around 10 hertz, you'll see a third motor unit, and so on and so forth. So that is the rule of fives. But if you only have one motor unit on your screen and it starts firing past, say, 12 to 14 hertz, and another motor unit hasn't come in, that's a problem. And at that point, you're going to move your needle to a different area of the muscle and see if you can replicate that. Okay.
Dr.
Yeah.
I know you asked us this at the beginning, and I'll just make this brief, but I actually did a test yesterday, and I know I haven't got the new one to you yet, but I actually feel like I saw that for sure for the first time, where I saw 18 cycles per second of the same, look like the same motor unit firing.
Good.
So
Good.
that was pretty neat.
And did you switch to a different part of the muscle and replicate it?
That one specifically was the EDB, and it was the first time that I had done that, and I was sweating bullets. So I can't remember if I ended up going to a different spot like I would have been one I was more comfortable with.
Yeah.
Sorry.
Yeah. So so tell us about your rationale for sticking to EDB. Why did you stick to EDB?
It was weak.
Okay.
The toe extensors were weak, and I was basically what I feel like I saw, and I know I haven't given you the report yet. But, it seemed like the lady was previously large, had lost about 200 pounds through a weight loss surgery. And I noticed that she crossed her right leg over her left, and asked if that was common for her. And she said, yeah, I always cross it this way. And so I tried not to bias myself because I didn't want to, but basically, I know I don't want to go on a rabbit trail, but I saw a lot of things like the peroneal motor had very low amplitude, and I wanted to make sure I got L5s and peroneal or fibular.
So what is one of the most common causes of peroneal neuropathy at the fib head?
Significant weight loss?
Significant weight loss, absolutely. Okay, because losing all that weight, the body starves itself. Okay, the nutrition is compromised, so that affects the nerve. A lot of these patients that have bariatric surgeries end up with polyneuropathy, because of that, and it takes away some of the padding that was around that nerve. Okay, there's no cushion around that nerve anymore, so it makes it more susceptible to on a compression. So what did the tib anterior show?
The tib anterior,
because Marcus, I don't care about the EDB.
I understand. The tib anterior was definitely was abnormal. I know for sure. Well, I say I know for sure. We'll see what happens when you look at it. But in my opinion, when I did the insertional activity, there was definitely increased insertional activity in terms of there was and I looked at it. There was fibs and positive sharp waves that followed pretty much every single time I did it.
And how was the recruitment in the tib anterior?
I'll have to go back and double check.
Okay. Okay.
We're three therapists short and we picked up on our patients. So
Okay. Yeah.
I literally have parked it in my office, but I haven't had time to go back over it.
So
I'm sorry.
So in a case like this, what's a more significant finding? A few fibs and positives or a change in recruitment?
A change in recruitment.
Absolutely. Absolutely.
Yeah. I will double check that before I get it to you.
I mean, you can lose 10% of your axons and have fibs and positives, but have completely normal, recruitment.
But I do remember on our amplitude for the perineals, and I feel like it was confirmed through the EMG from some of the things I saw. The amplitude was like at about 1.4, 1.3.
For the
microvolts.
Off of the EDB?
Off the EDB.
What was it?
Should have went to the tib anterior. Dang it.
Yes, you should have. And what was it on the other side?
I did not compare to the contralateral side.
And you're going to be bringing her back in and
that's fine.
That. Yeah. Anytime, and this brings up a fantastic point. Okay. If you see a low sensory amplitude or a low motor amplitude, you are obligated to check that nerve on the other side. Okay. And why do we do that? Why do we check a low amplitude or a no response on the unaffected limb?
For percentage?
You want to be able to approximate, one, that what you did on the affected side is not a technical error, and then number two, if it's not, you can approximate the degree of axon loss. So if you had off of the EDB on the affected limb, you had an amplitude of 1. On the unaffected side, the amplitude is 5. You can approximate that there's about 80% axon involved. So don't even send me that report until you check the other limb. Okay.
Yeah, yes. I can get her back in. I already talked with her. I said
good.
Sometimes I make mistakes. So anyways.
No. Gotcha. You don't tell her you make mistakes. You tell her that you need to do a little bit of additional testing to get the most accurate answer to what's going on.
Okay.
That's how you, and patients, if you tell them, well, sometimes I screw up, so I need to bring you back in. You think they're going to come back in? No. But if you say, Mrs. Jones, I've looked at your results. There's a few other things that I'd like to test to get a better idea of the severity and the location of the lesion. Can I bring you back in and do a few more things? And I've never had a patient tell me no when you approach it like that. If you tell them, yeah, I screwed up, or I was on my allergy medicine that morning and I just missed a bunch of stuff.
Do you want me to also look at the tib anterior as well while I have her in there?
I do.
Okay.
Absolutely.
Okay.
Yep.
Okay. So just look at those bilaterally or look at the EDB as well?
Anytime you have a low amplitude, then it becomes incumbent upon you to check that particular nerve on the contralateral side.
Okay. Thank you, Dr. Brooks.
So very, very good discussion. So we've got a good idea now of what constitutes very mild or mild versus moderate versus unsevere. So let's now, and it looks like Sabrina either made it home or back to the office there. So again, we talked about this last time. Why do we care about telling or trying to assess the unseverity? These are all some of the reasons here. But what do your referring physicians almost always ask you if you don't discuss what the severity is? They ask you, well, how severe is this? Okay, because how they treat that patient, okay, is based upon that severity. Okay, so if for example, you have a carpal tunnel patient that has an atrophied thenar eminence, and when you test them, it's severe or very severe, Okay, but you don't put that in your report findings. You just say, sensory motor axonopathy affecting the right median nerve at or about the wrist. Okay, a good surgeon is going to ask you how severe it was. A really good surgeon will look at that patient's thumb, at that patient's thenar region and know that it's severe because of the atrophy. But in less obvious cases, if it's moderate plus to severe, a lot of times, especially if there's motor loss, if there's significant weakness, or if there's atrophy, they're not going to waste their time doing splinting and doing therapy. Okay, they're probably going to want to decompress that nerve before more axons, are lost. Whereas the opposite of that would be is the 28-year-old workers' comp patient who's got some very mild carpal tunnel, but they tell you their pain level is 10 out of 10 in that hand. But when you test them, it's very subtle changes. Okay, they're probably not going to release that patient. They're probably going to treat that patient conservatively with splinting, with an injection, or with therapy. Okay, so that's the main reason that we assess severity, is because we want to be able to manage our patients correctly, or make sure that our patients get managed correctly. Okay, so believe it or not, there are some studies out there that do look at the severity of cubital tunnel syndrome. And if you look at these, it's pretty much what we've talked about that, okay? Mild generally only involves some slowing, okay? When you get to the moderate level, that's when you start to see a reduction in that sensory amplitude, and you may even start to see, a slight reduction in that motor amplitude. What all these studies do not address, there's two things that they do not address. They do not address conduction block, and they do not address needle EMG findings. Okay, this study done in 2004, his grading scale only looks at motor slowing across the elbow. It does not assess the sensory component. It doesn't, address motor amplitude or sensory amplitude. It doesn't address, needle EMG findings. Okay, so as far as I'm concerned, this is sort of a turd here. Okay, because I've seen motor slowing across the elbow 28, 29 meters per second with completely intact sensories and normal motor amplitudes and normal EMG, and I'm certainly not going to call that unsevere. Okay, and those of you that were with us last time, Dr. McKibben and I, almost 10 years ago now, we had a study that, and we developed a grading scale that you can apply to almost any type of focal neuropathy. You can apply it to tarsal tunnel syndrome. You can apply it to peroneal neuropathy at the knee. Radial neuropathies, and as you see, it pretty much fits with the standard things we've talked about, i.e. very mild, being only comparative or short segment slowing abnormalities, versus mild is more slowing. Then you get into moderate, which generally involves a loss of sensory amplitude, and then into severe and very severe, which involves loss of the sensory response, and as severe as potentially losing that motor response. Okay, so let's take a look. This is it says CTS, but it's cubital tunnel syndrome. Okay, so when we look at ulnar neuropathy at the elbow, and I may use the term cubital tunnel syndrome, guys, where is the cubital tunnel? Somebody answer that question.
It's around the elbow.
You know, but more specific.
Between the medial epicondyle and the olecranon?
That is the retroepicondylar region. Where is the cubital tunnel? Where's Bill Dodson? Bill Dodson.
Come on, Bill.
Okay.
I'm right here.
Is Bill with us?
I am with you.
Bill, where is the cubital tunnel?
Distal to the posterior aspect of the, it's
distal to the medial epicondyle.
medial epicondyle, and not to be confused with the posterior aspect of the medial epicondyle, the whatever it's called. I don't know. I forgot.
Yeah, so the cubital tunnel is a fibrous tunnel between the two heads of the flexor carpi ulnaris.
Right.
So it's distal to the actual elbow. Okay. So when surgeons do a cubital tunnel release, not only do they make sure the nerve is not entrapped behind the medial epicondyle, they generally will release that fibrous arch, between the heads of the, FCU. Okay. So that's the two areas typically where the ulnar nerve will become entrapped. At the cubital tunnel, i.e. between the heads of the flexor carpi ulnaris, and then secondarily in the retroepicondylar region. There, okay? So, again, when I use the term cubital tunnel syndrome, what I actually mean is ulnar neuropathy at the elbow. So, very mild, okay? Like we talked about, that's something that's a short segment or that's a comparative test, okay? So oftentimes at the elbow, we'll see, for example, a nerve conduction velocity across the elbow in an across elbow section, maybe around 47 or 48 meters per second. If you just look at that number in isolation, you're not going to get a red box, okay? The dreaded red box of death there. Because according to your normative values, 47 or 48 meters per second is normal. But what if that forearm conduction velocity is 62 or 63 meters per second? Okay? So there could be a difference of 14 or 15 meters per second between the across elbow and the forearm segment. So for cubital tunnel syndrome, if the motor NCV across the elbow is greater than 10 milliseconds slower relative to the forearm NCV, that's abnormal. And because it's a comparative test, that qualifies it as being very mild.
Did you say, I'm sorry, you said 10 meters per second?
Greater than 10.
Across the distal segment.
Comparing the across elbow to the forearm segment or the distal segment.
Okay.
Okay. I saw a couple of cases yesterday where the across elbow segment was 48, 49 meters per second, and the forearm segment was 62 meters per second. Okay, so that's very subtle. It's comparative. It's one nerve conduction velocity relative to a different segment, okay, but within the same limb, okay? So that would qualify as very mild.
And what about if you have, well, you say if you're obligated to do the opposite side, if you have, that's speed. We're not talking about amplitude. Okay.
In this case, you're not obligated to do the other side, because the reason to do the other side is, one, if the patient is symptomatic on the other side, or if you have a decrease or absent response in the affected limb. Then you have to check that nerve on
Right.
the contralateral limb.
Dr.
Hey,
Brooks?
Dr. Brooks.
Yes, Bill.
Sorry, on the checking the contralateral side, that's with a decreased amplitude for either motor or sensory, or just motor.
Or sensory. Yes.
Okay, thank you.
Yes. Bill?
So if you saw that 10 meters per second differential, would you go ahead and go for the FDI?
You certainly could. And oftentimes I will. Yeah. Oftentimes I will. Because Bill, what is unique about the fascicles of the FDI around the elbow compared to the fascicles for the ADM?
They're primarily motor.
They're primarily motor, and they're huge.
Ginormous.
They're much larger than the fascicles for the ADM, and they're more superficial. Okay, so what size fascicles are more prone to compression? The smaller ones or the larger ones?
Larger ones.
The larger ones. So yes, so that's a good point, and you certainly could do that.
So if you saw a 10 meters per second differential, but you didn't see much going on with the FDI, that would still be very mild, right?
I would consider that to be very mild. Yeah.
Now, what would happen if you saw, a significant? So on the FDI, is there a 10 meter per second differential law as well?
Yes. Yes.
So if you saw that, that would still be very mild as well.
Yes. But what if recording off the FDI across the elbow, the speed of that nerve was 39 meters per second? So how would that change our severity? It would change it from very mild to mild.
Okay, so if both
because there's an absolute slowing. There's not a relative slowing, there's an absolute slowing there. What other demodeling process do we see with the ulnar nerve at the elbow? Very, very commonly. Other than slowing. And it involves blocking.
Conduction block?
Conduction block, okay? If you look at these grading scales, all of them, next to none of them address conduction block.
But yours does.
Huh?
Yours
Ours doesn't either, because we really didn't get a chance to study that. Okay, we went back and did a retrospective review of a bunch of studies, and with the exception of one or two of them, none of them addressed conduction block. And so that is a fantastic study that needs to be done going forward, is looking at impairment and severity grading that involves conduction block there. Now, that being said, what's in red here under this mild, that's a suggestion. This is what Dr. McKibben and I sort of use. We don't have any proof of it, okay? But we all know that motor conduction block in excess of 20% is significant. That's abnormal, okay? So we are surmising, based on review of literature and clinical findings, that potentially a conduction block of between 20 to 50% at the elbow may constitute mild. Okay, where did we get that 50% number? Anybody there that's an old timer that's been a PT for 20 or 25 years, where does this 50% number maybe come from? Am I the only person here that's been a PT for?
Well, I mean, you're talking about law of averages. It's either there or it's not. You kind of
there's a book that we studied in PT school 33 years ago. Okay, the author was a guy by the name of Basmajian, and the name of the book was Muscles Alive. And he did studies in animals, and he found that you could eliminate as much as 50% of the axons supplying a muscle, and that muscle will still give you 4 to 4+ out of 5 strength with 50% of the axons gone. It'll still give you a manual muscle test of between 4 and 4+ out of 5, which to me is just fascinating there. So that's sort of where that 50% comes from. Okay.
Dr. Brooks, you just depressed me.
How's that?
Because I've been in the field for, this is my 25th year of practice, and you just called me an old timer, and I actually remember that from school.
Fantastic, man.
Nah, I don't know. That makes me
I
sad.
love it.
An old timer.
I love it, man. I started PT school almost 34 years ago now. Holy cow, has time flown by, here. Okay, but that's a fantastic book. It is out of print. I've got an old copy of it. But isn't it fascinating that you could lose 50% of the axons to a muscle, and that muscle will still generate 4 to 4+ out of 5 manual muscle test? I mean, that is amazing. Okay. Okay, so now we're getting into moderate cubital tunnel here. Okay, and I'm going to pause for a second because this is going to bug the heck out of me with my OCD here. So I'm going to change that to cubital tunnel syndrome so I feel comfortable with myself here. There we go. Okay, so now we're getting into moderate. Okay, so obviously a reduction in the sensory nerve amplitude is going to qualify as being moderate. But what about on a conduction block? What about a conduction block greater than 50%? Could that maybe be, moderate? Something to think about. What about EMG abnormality? What about fibs and positives? What about large amplitude motor units? What about fast firing motor units? Okay, certainly when you start to see EMG abnormalities, and I'm not talking polyphasics, okay, because polyphasics are overrated. Polyphasics are overrated unless there's an abnormal recruitment pattern, okay? So certainly fibs and positives, large amplitude motor units, reduced numbers of functioning motor units certainly will bump us into that moderate, category. Now we're going into severe, okay? So what's common among severe focal lesions? Absent sensory response, okay? The start of significant reductions in that motor, amplitude. What muscle, with an ulnar neuropathy at the elbow, what muscle are you going to see atrophy in first?
FDI.
FDI. And why is that, Bill?
Because it is primarily motor.
Yeah, it's primarily motor, and at the elbow, they're the largest, most superficial fascicles.
The largest, yeah.
Yeah, so they're more prone to being compressed. Okay, the fat guy trying to squeeze through a narrow area is going to get compressed more than the skinny guy. Okay, so the larger fascicles are more prone to compression.
It hurts my feelings when you make that analogy about me.
Well, have you ever been stuck between in a narrow area?
I'm just giving you a hard time.
You shouldn't feel bad unless you've gotten stuck. Okay. So again, the most common findings that you're going to see in a severe cubital tunnel is the absent sensory response, and then that motor amplitude is going to drop. And you're most likely going to see EMG abnormalities. Now, what about conduction block here? Okay. What about, say, a 90% conduction block, at the elbow? What do you think the strength of the ADM and the FDI is going to be if there's a 90% on a conduction block. We said
Out
that.
of 2 out of 5?
Yeah, probably a 2, maybe a 2+, out of 5. But is there going to be atrophy of that muscle in a
No.
conduction block? There's not. Okay. What type of EMG abnormality are you going to see in the case of a 90% on a conduction block?
None.
Wrong.
Really?
Really? Yeah.
Like the rapid fire.
Yeah. Yeah. Because 90% of the axons are blocked, you're not going to be able to generate motor units. Only 10%
Oh.
is functioning motor units.
Yes, but you're not going to have collateral sprouting, so you're not going to have any of those.
No, you're not going to have any of that. Are you going to have fibs and positive sharp waves?
No.
No. What you're going to see is a reduced fast firing recruitment pattern. Okay, because of that significant conduction block.
Can I put in a request for us to do soon another EMG identification interpretation webinar?
Yeah. EMG, EMG is fairly easy if one, you get the needle into the right muscle, okay? And if you get it in the right muscle and it's denervated, the stuff's going to be there for you. But what's difficult, Kelly and everybody, what's difficult is judging recruitment. Okay. So my screen is not filling up with, well, does that mean anything? No, that's a decreased interference pattern. Okay. If there's truly a loss of motor units, what's the thing that you're going to see when you try to recruit those motor units?
I just dealt with this last week, so John and I were talking about it. It's going to be, you're not going to get more motor units. They're going to start to go fast firing.
They're going to be fast. They're going to be fast. They're going to be fast firing. Because if you've lost, if 90% of your motor units are not functioning, either because of axon loss or because of a conduction block, the ones that are left that are working are going to have to work much harder in order to generate force. And that translates to they're going to be fast firing. Okay? Very severe. Okay? Absent sensory response, potentially an absent motor response, or a motor amplitude that's less than 10% of the lower limit of normal, so less than 0.4. Okay? That's very severe. That's 96% of your axons are gone. Okay? What are you going to see on EMG? What's the most striking thing that you're going to see on EMG?
Decreased insertional.
Potentially, if the muscle has become unfibrotic. Yep. If there's not a motor response, you're probably not going to see any motor units, or you might see one, but the motor units you do see are going to be doing what?
They're bigger.
And more important, they're
Rapid.
They're rapid firing, guys. That's the rapid firing motor units, and not bringing in a second motor unit. That's a worst case scenario there.
So if we see lots of variety on the screen, we're good. If I'm getting lots of different stuff as I'm kind of there plunking.
Well, are they recruiting normally? Is a second motor unit coming in at 10 hertz, a third one at 15 hertz? Okay. Needle EMG starts with being able to isolate a single motor unit. Okay. So if you have a muscle that is clinically weak or atrophied, and if you cannot isolate, because your technique's not there yet, if you can't isolate that first motor unit, you're not going to be able to assess on recruitment, because once you get more than 3 or 4 motor units on that screen, you can't assess recruitment. Okay, so the one skill that I would ask all of you to develop, okay, once you get past being able to put the needle into the correct muscle, is the ability to isolate a single motor unit within that muscle.
And that has more to do with technique and handling.
That's technique, experience. Yes, yes.
Getting them to relax.
EMG and nerve conductions are a perishable skill. Okay, it's a perishable skill. Just
Hey,
like
Dr. Brooks.
Yep.
I got a quick question on this. So, and you cut out a second ago, so I apologize if you just covered it. But on the fast firing, is it possible that if you're sticking that needle, say, into the correct muscle, and they're firing, and you're seeing multiple motor units, is it possible that because you're not able to isolate it, that even though they're kicking in that second and third early on, that because you haven't isolated it well, that it still may have fast firing, you just didn't have good enough technique? Is that what you're saying?
That is possible, but
Okay.
that's not something that generally you clinically see.
Okay, all right,
Okay,
thank you.
if you've got a very weak atrophied muscle, it's very, very rare, in my experience, that you're going to see 4 or 5 or 6 motor units, kicking in there. Okay, so yeah, guys, this is a perishable skill. You need to be practicing this every week. Every week. Okay, so, man, holy cow, it's 8:30 here. So let's look at some cases here. Okay, so who wants to take a look? Who feels lucky here tonight? And if I don't get a volunteer, I'll choose somebody.
I'll put myself under the ringer.
Okay, so Kelly, this is a 52-year-old female with right-sided neck pain and numbness and tingling into digits 4 and 5. Okay, now, how often are we going to see a C8T1 Redic?
I have no idea.
Like never. Like never. I see a couple a year. Okay, so when you see a patient that has numbness and tingling into digits 4 and 5, what's your primary differential diagnosis?
Cubital tunnel syndrome.
Ulnar neuropathy at the elbow. That's right. That's right. Okay. So, looking at these findings here, reflexes are good. Sensation is intact. Even though they're reporting paresthesia, when you actually test them, their cutaneous sensation is still intact. This is going to happen all the time. But there is a little bit of weakness in that right FDI and ADM, negative Sperlings, negative Tennells at both the wrist and elbow. So Kelly, just look at the ulnar components. So this first table here are the sensories. So tell us about this right ulnar sensory test. Is it normal or abnormal?
Well, let's see, peak, amplitude, it's looking pretty normal as I'm going through. No, ulnar, I'm on median, hold on.
Yeah, latency is normal.
Yeah, it looks good.
Sure. What about amplitude? Amplitude is normal.
5, so I'm happy, but it's not the same as the median, but I don't know.
It shouldn't be because it's a smaller nerve. Okay. And conduction velocity is normal. So essentially we have a normal sensory study, right? Okay. So what severity grades can we automatically eliminate with a normal sensory test?
Say that question again. What can we automatically?
What degrees of severity can we eliminate with a normal sensory test for the ulnar nerve?
Well, I would say you're automatically there's no very severe and there's no severe.
Yeah, so this probably is not severe because we got a normal response. Probably not going to be, moderate, but we can't entirely, go there until we look at our motor. Okay, so Kelly, right here, right ulnar motor, off of the ADM. Okay, so look at this data. We have stem points at the wrist, below and above elbow segments. Here's our amplitudes. Here's our conduction velocities here.
Looks
Okay.
good.
You sure?
Yeah.
You sure?
Well, the velocity is
You
still
sure it
there.
looks good?
Well, now you're making me question myself.
What did I say about comparing?
10 meters per second.
Yeah.
Oh, yeah. Okay. 10.
Yeah.
Oh,
So
that's
comparing
there. That's where I'm
across
supposed to
the
put that?
elbow to the forearm, we have greater than 10 meters per second difference. And this is not going to give you, it's not going to give you a red box.
Yeah, got you. Okay, now I see it. I've never known where to look for that. Okay, I get it.
Now, same nerve, but recording off of the FDI. Okay, latency, amplitudes. What do we have going on here?
Oh, I can't see. Hold on a second. My thing's blocking. Well, at that point, you're also looking at the same thing.
You're looking at essentially a normal across elbow NCV that becomes abnormal when you compare it to the forearm segment.
Got it. Okay.
Okay, so to summarize this case, we have normal ulnar sensory, but we've only got slowing across the elbow relative to the forearm. What's the severity of this case?
Looking at that with that, I would say, well, let me look at my little list.
Look at your notes. It's relative slowing.
Greater than 10, it would be
Comparative
very
slowing.
mild.
It would be what?
I wrote down comparative.
It would be
Very mild.
very,
Unless I should have put mild and I put it in.
no, it's not mild. It's very mild.
Very mild. That's what
Because the only abnormality is
Is the
when you
comparison.
compare one segment to the other.
and there's no abnormality with respect to normative values.
All of the normative values are normal. See, and that's where the red box of death will eat you up alive, is because it only compares this value to that value.
Right.
And if it's greater than that, it's not going to give you a red box, but you have to compare. And this is why you do this as you're doing the test.
Right.
You're analyzing your data as you do the test. Okay, so when you're done and that patient says, well, what did you find? You said, well, I really can't tell you because I've got to go back and look at this and I've got to have my mentor look at it and then he'll get back with me and tell me what's wrong. So let me call you in a couple days. Okay, guys, analyze your data as you're collecting it. And at the end of that exam, provided there's no technical errors, you'll know what's going on. And that makes writing your report easy. So this is a very mild, primarily motor demyelinating neuropathy affecting the right ulnar nerve at or about the elbow.
Well, can we talk about the median nerve now?
No, because because this is about the ulnar nerve.
Yeah, but can I just ask you a question since we're at 69 and 31? Would that be something I would normally that would also be right there on right median motor at the APB? Should I be looking at that similarly?
So you're looking at this, right?
Yeah, do I have to say, oh, maybe very mild carpal tunnel?
No, you don't. Do you know how to do the motor stimulation of the median motor in the palm?
Yeah.
You do.
Oh,
Okay.
no, I don't. No, I don't.
No, you don't. You do it for the sensory nerve, but you don't do it for the motor nerve. Okay. So we'll leave that alone right now. And if you have questions about that, Kelly, holler at me, okay, and we can talk about it. But
at the bottom line, it's a very short segment, so
it's a short segment with a normative value of 29 meters per second.
got it. Okay.
Okay, so anyway, okay.
Thanks.
Next case, Bill Dodson.
Oh, crap. I mean, yes, sir.
Okay. So take a look at the owner sensory and the owner motors and tell me what's going on here. How about that owner sensory, normal or abnormal?
Normal.
Normal. How about the right owner motor recording from the ADM? Amplitude's normal?
Amplitude is normal.
Amplitudes are normal. What about these conduction velocities?
Negative. They're not normal.
Okay. So what we have here is we have an absolute slowing of a motor conduction velocity. Yeah, it's 22 meters per second difference, but this value right here is absolutely slowed. You don't have to compare it to anything else because it's slow.
Same thing on the FDI.
And the same thing on the FDI. Bill, why do you think the FDI is maybe just a little bit slower than off for the ADM?
Because they're larger diameter.
Yeah, larger. Yep, more prone to compression. So based upon this, what's the severity of this lesion?
It is a mild.
It is mild. Do we all understand why it's mild? Because there's absolute slowing. It's not comparative like we had on the previous case. There's absolute slowing. So this would be a mild, primarily motor demyelinating neuropathy affecting the right ulnar nerve at or about the elbow. Okay, who feels lucky?
I'll give it a go.
Go, Mark. Oh, Scott, go for it. Okay, so take a look at that right ulnar sensory and tell me if that's normal or abnormal.
It's normal.
You sure?
Hold on, don't circle that. Give me a chance to look.
Okay.
Nah, I know what it is. So yeah, I missed that one.
Yeah, so what's going on with the ulnar sensory component of this nerve?
Ulnar sensory component. Is that axonal?
That is sensory axonal.
Woohoo!
Yeah, so we have a low amplitude sensory. So right off the bat, what severity are we going to be at?
I'm going to say mild or moderate.
It's not going to be mild. Okay,
Moderate.
mild is only slowing.
Okay, all right. So
here we have a diminished sensory amplitude.
Got it.
Okay, so this is going to be what, Scott?
Moderate at a minimum.
Moderate. And what else are you going to do? Are you going to check this? Are you going to check the left ulnar sensory nerve?
Yeah, I would think so.
Yes. And what if that left ulnar sensory nerve has an amplitude of 15? What does that tell you? What little bit of information can you glean from that?
Well, it's really slow then.
No, it's not slow.
I mean, no, I'm sorry. I'm not sure. Go ahead.
Yeah, 3 is roughly 20% of 15, right? If you compare side to side.
Okay.
3.1 versus 15. So 3 out of 15 is 20%. So what that tells you is that only 20% of your sensory axons are being depolarized. Only 20% of them are working. Okay, so there's certainly a sensory axon component here now. Okay, now come down here and take a look at this right ulnar motor off of the ADM. And in the interest of time, I'm going to say look at the amplitudes and look at the conduction velocity. So here are your amplitudes right here, and here's your conduction velocity. So
well, the amplitude, there's quite a drop off.
Yeah,
Yeah.
The amplitude is normal at the wrist, but it drops at the elbow. The same thing happens with the FDI. It's technically a normal amplitude at the wrist, but it drops about 40%, over 40% at the elbow. What do we call that? What is that phenomenon called?
Is that Wallerian degeneration?
No, it's not. Why is it
Oh,
not?
conduction block?
Yes. Yeah. Distal CMAP amplitude is normal. If it was Wallerian degeneration, they all would be small.
Oh, I'm
right?
sorry. I looked at it too quick.
Yeah.
Yes.
So this is what, Mark?
This is conduction block.
This is conduction.
Partial conduction block.
This is partial conduction block. Okay, so we have partial conduction block, and then what about these nerve conduction velocities here?
Yeah, they're abnormal. I mean, there's
It's mildly slowed, off of the ADM. But what's up with this? How come is it slow in the forearm segment? How can the problem be at the elbow off of one muscle and in the forearm off of the other muscle? Where's the problem at when you see this particular appearance? Does this patient have 2 lesions, or is there 1 lesion? And if there's 1 lesion, where's it at? And I think, Kelly, you were going to try to say something maybe.
I was just going to say it'd be below the elbow, and I'm starting.
Yeah. So what is the common site of entrapment of the ulnar nerve that's slightly below the elbow? What's that area called?
Isn't there that fiber that goes across?
What's that area called?
Cubital tunnel?
It's the cubital tunnel. Okay, so this patient's problem most likely is slightly distal to that medial epicondyle there. Okay, Scott, take a look at the EMG here. Tell me what's going on with the EMG. And again, in the for the sake of time, I will mark these here. So we don't have any fibrillations or positive sharp waves. We don't have any abnormal insertional activity. We do have some larger than normal amplitude motor units in the ADM and the FDI. And we have a reduction in recruitment, quote unquote, or a reduction in the amount of volitional motor units. So somebody tell me what this tells us when you have larger than normal amplitude motor units.
Is it just working harder?
No, that's what maybe this is here. But if you have a larger than normal amplitude motor unit, what does that tell you?
Chronic.
It's chronic, and it's due to what?
Sprouting.
Yes. It's a loss of motor axons with reinnervation via collateral axon sprouting. Okay, so we have larger than normal amplitude motor units. We have abnormal recruitment. We have slowing somewhere around the elbow, which is a demyelinating process. We have conduction block, motor conduction block at the elbow, which is a demyelinating process. And we have a lower than normal sensory amplitude, which is sensory axon problem. So put this all together. What's our severity?
Severe.
Let's say moderate.
It's moderate.
He's got an abnormal EMG.
So what? Big whoop-de freaking do. Did we say that an abnormal EMG means severe? No. I know you.
3 notes here. Abnormal EMG is severe.
No. Yeah, large amplitude motor units doesn't mean that it's severe. This is moderate. Okay, this is a moderate sensory motor, comma, axonal and demyelinating neuropathy affecting the right ulnar nerve at or just distal to the elbow. And you could even say, you know, parentheses, cubital tunnel region there. Okay, why is this not severe? Tell me why this is not severe. One, we still have an intact sensory response.
Oh, that's true.
And our distal motor CMAP amplitudes
It's
are still
preserved.
normal. Yeah, so this is moderate.
Okay, because okay, if they're okay distally, basically that means that we didn't lose too much. Otherwise, we would have lost further.
If they're okay distally, there most likely is not significant motor axon loss.
Right, it's more conduction block-ish.
But if the amplitudes are smaller, proximal to the site of the lesion, then that is conduction block. Conduction block is a demyelinating process. Conduction block is not an axon loss process. Okay, last case here. Who feels super lucky? Here, actually, this is actually going to be sort of easy, but who wants to do this one?
I guess I'll give it a go.
Give it a go. Okay, start with the left ulnar sensory test. You know, what's our
Okay.
finding?
No response. That's
No
not good.
response. No response. So
Yeah.
right off the bat,
I'm thinking that's probably already potentially
this could
severe.
qualify as a severe.
Yeah.
Take a look at your left ulnar motor off of the ADM.
Okay.
Take a look, you know, look at amplitudes.
Looking at the
Look at-
amplitudes, yeah. They're a little low.
They are low. They absolutely are low. And
Yeah, they're below that 4.
yeah, plus this would have been, who did this? This is one of my guys. Dusty did this. He actually shot the ulnar motor on the other side and it was 9.7.
Okay. Yeah.
So it's certainly, this certainly is low. That's
Right.
about 60% lower
Right. Right.
than that, you know, contralateral side. So there certainly is axon loss. What about off of the FDI here? What are you seeing with this FDI? Look at
It
amplitude.
looks like a conduction block or
It
something.
looks like a fairly normal distal
Yeah.
motor CMAP, but look how it drops, you know, once you get above the elbow.
Right.
About a 50% conduction block
Right.
at elbow. Now, Mark, go back to this left ulnar motor off of the ADM.
Okay.
Look at our conduction velocities here.
Yes, sir.
Okay, are they
It's,
normal or abnormal?
Normal because it's only 9.
They're normal.
Yeah.
I mean, how can you have a low amplitude but normal conduction across the elbow? How's that possible? Well, it's possible because with the condition, the compression affecting the fascicles to the ADM, it's primarily motor axon loss. There's not a significant demyelinating process. It's primarily motor axons. But when you get to the FDI, is this primarily axon loss, or is this primarily a demyelinating, or is this both? Just based upon what you're looking here at, in your nerve conduction table.
Yeah, I would say it's probably a little bit of both. I would say
Well,
more.
what in this table is telling you that this is axon loss? We've got a normal.
4.9, I guess. I don't know.
No, we don't care about that. We only care about the most distal.
Distal.
Yeah.
Then nothing's telling me that.
Yeah.
Now.
So what's going on here? We have we have conduction block,
Slow conduction velocity.
and we have slowing here.
at the
So it's,
FDI.
yeah, so this is when you record off of a different muscle crossing the same segment at the elbow, we have a primarily demyelinating process here. Then we do EMG here. And when we do our EMG, notice we're not seeing fibs and positives here.
Right.
We're seeing increased amplitudes, and we're seeing fast firing motor units here. Okay, so we would expect to see this increase in amplitude when we stick the ADM, because we already have established that there's motor axon involvement, right? Off of the
Right.
ADM. But we didn't see evidence in our nerve conduction of any axon loss. It was primarily demyelinating. But when we get to our EMG table, oh, lo and behold, we have increased amplitudes and we got fast firing motor units when we stick the FDI. So even though the nerve conduction in this case showed a primarily demyelinating process, when we actually stuck the muscle, then we saw evidence of some motor axon involvement also. Okay,
Dr. Brooks,
yes.
Very quick question. Amplitude, what, I forget, what's the number to make it to say that it's increased? I apologize, I can't remember.
That's a great question. Okay, does anybody know that number?
40%?
Nope. Remember, we're doing EMG here. Okay, so you can only analyze amplitude of a motor unit if you're able to see and isolate that single motor unit. Okay, so a normal type 2 may go up to 5 millivolts, okay, during a normal contraction, and it can go as high as 6, 7, or 8 millivolts during a full contraction. Okay, so if you're isolating, as you should, a single motor unit, if you see something that's 7, 8, 9, 10, okay, that's going to be large. I think in this case here, I want to say that that these motor units were like 12 or 14. You know,
1,000?
Yeah. Yeah.
Oh wow.
And they were firing fast also.
Yeah.
Okay.
Huh.
So Mark, what's the severity of
severe?
Severe. And do you want to take a stab at speaking the impression?
Oh, brother, I always suck at these.
So a severe. Okay.
Severe axonal.
Okay.
Axonal.
Freeze. Is it
okay.
sensory
motor? Sensory motor.
Sensory motor or both. So in this case, it's sensory motor. Is it axon loss? Is it demyelinating or both?
Axonal and demyelinating.
Okay, axonal and demyelinating, affecting the
left ulnar nerve
at or
about the elbow.
There you go.
At or just distal to the elbow.
Yeah, at or about the elbow. Because here, you know, we've got slowing in that in that across elbow segment. So in this case, you know, I would say at or about the elbow. So a severe sensory motor axonal and demyelinating neuropathy affecting the left ulnar nerve at or about the elbow. And and what makes it severe? There's only one thing here that makes it severe. And
no response.
No response. First thing we looked at.
The loss of a sensory response. Yeah. That's exactly right. Okay. Good. So that was a lot of information. Basically what I gave you in the last hour and a half is something that we would normally do in like a full day mentorship or a full day course here. It's a lot of information. But do you see where there's commonality between, say, carpal tunnel syndrome and cubital tunnel syndrome when you're, you know, when you're looking at certain parameters like sensory amplitude and, motor amplitude, EMG, that type of stuff. When you get into the woods, down into the weeds, and you're trying to figure out very mild versus mild, that's not as big a deal as trying to delineate between, say, a mild and a moderate and severe lesion, because that's going to affect how this patient is treated. Okay. A lot of you guys do, ultrasound. Okay. What would you expect to see when you did, if you did some neural sonography of the ulnar nerve at the elbow? What type of changes are you going to see, in your ultrasound?
That's a really good question.
Decreased diameter?
Increased diameter.
Increase in diameter.
Ah, okay.
Because the nerve's inflamed and it's irritated. So it's gonna have a larger cross-sectional diameter. What's the normal cross-sectional diameter of the ulnar nerve at the elbow?
Was it 0.09?
Yeah, it's 9 square millimeters, or 0.09 square centimeters.
Right.
Okay? Compared
It's one less than the point.
It's one less than the 10, which is the median nerve at the wrist. Okay. What else might you see, especially in this more severe case? Okay. Other than just seeing a larger than normal amplitude, what might you see in terms of echogenicity of this?
You would see fascicular, you would see darker spots with lesser light spots. You would see,
Yeah, so what do we call that? When we do ultrasound, we call that hypoechoic, right?
right.
And we call that a disruption of the normal fascicular architecture.
Right.
Correct. Yeah. So again, that's something that you could see if you did ultrasound. I've been just in the past, just short period of time, per the AANEM's, practice parameters, we've been doing, neural ultrasound on all of our carpal, cubital, and tarsal tunnel cases. And it's amazing what you're going to see. I've seen just this week, just through today, I think I've seen 3 cases of patients that have clinical signs and symptoms of carpal tunnel syndrome, okay, but their EMG and nerve conductions were normal. But when I saw yesterday, when I ultrasounded the median nerve at the wrist, the cross-sectional diameter was almost 15 or 0.15. Okay, so that that ultrasound is a good adjunct to your nerve conduction test, especially if it's a normal nerve conduction test, or maybe just a very mild. I also saw a ganglion cyst within the carpal tunnel here a couple days ago. So if you've got the ability in your facility to use that ultrasound to do neural sonography, I would recommend you do that also. So, oh crap, we're late. Okay, questions, thoughts?
I have an announcement.
Bill, if nobody has any other questions, and again, as normal, any of you can feel free to to email me or call me or text me or whatever. If there's not any questions, thoughts, comments, I'm going to turn it over to Bill Dodson for a PSA.
Last year I started a library of EDXs, and this year I'm going to be doing a library of musculoskeletal ultrasounds. That'll come later on. But so in order for us to do this library, the library is going to be used by all of us to look at normal and abnormal diagnostic examinations. So if you send in a study and you send it in blind, that means you block out the patient's name, their social security number, their doctor, their sex. I think you can put the sex in there. You can't put any data that's HIPAA violating, okay? And if you block out that information, you can get a 1 hour credit, I believe. You might want to talk to your mentor about that. So just imagine if you send me 20 studies, you get 20 hours of participation. That's a big deal. So even if you've only done 5 or 6 studies for you newbies, it's a big deal for you getting some of the peripheral hours done that are hard to get. Believe me, I know, because I got at the tail end of mine and I was struggling. So if you do that, that's going to be phenomenal. So here are the categories. So and I can send this to any of y'all. You can get a hold of me through at bill@paradigmpt.com. You can get a hold, just call up HODS. They'll send you my way. But atraumatic entrapment neuropathy to the lower extremity, and then the second one is to the upper extremity. Cervical radiculopathy, lumbosacral radiculopathy, motor neuron diseases, myopathies, nerve plexus disorders, neuromuscular junction disorders, and then peripheral neuropathy, peripheral polyneuropathies, and then traumatic mononeuropathies. Those are categories, but if you just send them to me, I'll put them in a category, and you'll get credit for this. This is, the fact that you do this study is great, and that's fantastic, and maybe you get paid for it, and then you get credit for it with respect to your studies. But to also get credit for it for your hours and stuff like that, this is good stuff. It's like free stuff. All you have to do is take off the names and all the other HIPAA stuff. So I encourage you to do that. And hopefully, we only have about 80 studies so far. I'd like to get it up to 200 studies, and so that everybody will be able to see, especially you newbies, you'd have a chance to take a look at some studies and see how they're worded and all this other stuff. So you'd be able to use the wording and compare your studies to that. And that's all I want to say about that.
Sounds good. Thank you, Bill. Okay, everybody.
Bill, what was your email address again?
Bill@ParadigmPT. That's PARADIGMPT.com, because .stud was already taken. By the way, VJ, you're in Houston. Give me a holler.
Sure. Well, and how do you access your library?
So we're trying to make this accessible on the internet, on our website, on the HODS website. But I need to get enough, and I really want you guys to participate, because if you don't,
okay, too. That's probably me and Ganesh will send you more with that.
Yeah. So, and even if you're new at this, send me your new stuff. It doesn't matter. I would rather see a new person to show other people that it's not so bad to start off with new stuff, and to have it, show where they need to make progress or whatever. And you take your name off too, so nobody gets to see who it is.
Okay.
Okay. So it's all private, and if you forget to block out something, I'll block it out for you.
Sure. If we miss anything, you can block it.
Yeah. I'm not. This is a time for people to learn on good and bad and the ugly.
Guys, I got to go. Have a good night. Thanks a lot. I appreciate everything.
All right, be well, guys.
Have a good
Thanks,
night, guys.
Okay, good night.
Thanks.
Thank you. Gotta go too.
Okay.
Yeah.
Bye-bye.
Thanks, Dr. Brooks.
Thank you.